here, these will be entrapped at the mesenteric artery root during this ascent. So maybe that's why they are they are still connected. Another congenital anomalies is renal agenesis. There is the absence of kidney. It can be unilateral or bilateral. When it is unilateral, it will relate to the hypertrophy of the existing kidney, and this is by compensatory mechanisms, of course. So there will be hyperfiltration, which increases the risk of renal failure later in life. So it means someone can survive with one kidney, but with precaution that this, because that kidney will be stressed to do the work which should be done by two kidneys. So that pressure may cause at a later time it can cause renal failure. So bilateral agenesis leads to oligohydramnios with lung hypoplasia, fat face with low set years, and the developmental effects of the extremities. This is called the Porter sequence, as it is seen in this figure. And this is, of course, incompatible with life, so nobody can survive without the kidney. So maybe in utero, it can be the fetus can survive because the blood received, it will be filtered by the mother, so the child can get, I can say, a relatively safe blood. But when the fetus is born, then the fetus will suffer. So that's why it is incompatible with life. So I think last time I mentioned the things when we are looking at the malformation for the esophagus. I said when the esophagus is not continuous with the stomach, usually in the fetus, usually the mother will have hydramnios, so a lot of fluid and a lot of amniotic fluid. And when the kidneys are having problems or urinary tract system is having problems, there will be not enough urine. There will be not enough amniotic fluid. The reason why this is oligohydramnios, because for the part of the amniotic fluid comes from urine. Thus, so if then the fetus is not producing urine, there will be a very little amniotic fluid. So another malformation is this plastic kidney. This is a non-inherited but congenital malformation. So it means it is not within the genes, but someone is born with. So there is a malformation of the renal parenchyma characterized by cyst and abnormal tissue. So you can find the cartilage like this in the blue. This is a cartilage which should not be there. So maybe there is a part of normal renal parenchyma, but other areas of the kidney have other types of tissue which should not be there in the kidney. So usually it is unilateral, but when it is bilateral, it must be distinguished from inherited polycystic disease, because as we see, there are cysts which are formed. So here turibona yitwa polycystic disease of the kidney. This one is inherited, while this plastic kidney is not. So here the word dysplasia doesn't refer to things like those we saw in cell injury and adaptation. Dysplasia has nothing to do with that. So dysplasia, in cell injury and adaptation, it refers to the changes which are similar to those seen in cancers. So the findings here in this plastic kidney and also in fibrous dysplasia we discussed in morning. So they don't refer to there's a changes, pre-cancer changes. No, it is just a name. So the polycystic kidney disease are a lot of pockets which are brown, some others are greenish, and so on. others are reddish. So there are so many cysts. That's why it is called polycystic or polycystic. It depends on the some they write polycystic. So this is the inherited reading two bilateral enlarged kidneys with cysts in the renal cortex and the medulla. So it can be autosomal recessive, which it presents in the infants and as worsening renal failure and hypertension. And in the newborns may be present with Porter sequence that we saw on the previous slide. So here on this one, so Porter sequence. So this is also associated with other congenital diseases such as congenital hepatic fibrosis, so which is almost like a cirrhosis. So, and thus, this patient will present with hypertension, portal hypertension, and hepatic cyst in combination with this kidney cyst. Ariko rero hari abantu bagira cyangwa abantu benshi bagira udukiste dutoya dukeya muri bagashyiramo muri kidney dukeya atari uko afite ibibazo ukabibona gusa ari for as an incidental findings when looking for other things, maybe you are checking if these organs are affected by cancer, metastasis, and then you find there is cysts. But these ones, they don't usually cause problems. But here, you see that with these multiple cysts, the kidney parenchyma will not be able to do glomerular filtration, and therefore they cause problems. So autosomal dominant form also presents in some patients, especially in young adults. So murabona ko recessive ikunda kugaragara mu bana, dominant ikagaragara mu bantu barinda gukura. As a hypertension, so these ones they present with hypertension because of increased renin, hematuria, and also renal failure, which will be worsening with time. So these are two in the APD1 and the cyst will develop over time and associated with very aneurysm, hepatic cyst, and mitral valve prolapse. So understand, and this is like a rule that usually there is no single malformation. When you see a child or a person with congenital malformation, there is another one also in other organs or systems. So ikindi bikunda gutandukana nuko akenshi igira ikiste bita simbukagira udukiste dutoya twinshi. So that is the main difference between them clinically. So the medullary cystic kidney disease, so it means there is a kidney cystic kidney disease, but which arises from the medulla, not in the cortex. So this is inherited autosomal dominant, leading to cyst in the medullary collecting ducts. So this diagram is showing the different patterns. So the first kidney here has no problem. There is another kidney with simple cysts. So no, but the disease is shown here. They are not only for the medullary cysts, the kidney. They are in general, or the cysts in general. So you can see that it is a simple cyst. They are toward the cortex. So recessive polycystic. So here we have many cysts inside the medulla, and then you have a dominant polycystic. Here we have the cysts all over, and they are done in a recessive way. Hydronephrosis. It should not be confused with the cyst. So hydronephrosis means the accumulation of the fluids within the kidney. Ngira ngo logically mushobora kumva bimwe mu biyitera, ikintu cyose cyatera obstruction maybe to the renal pelvis, to the ureter, even no hasi muri urethra and so on. The urine will accumulate hejuru noneho bitere dilation of the calyces and so on. So on a ultrasound or within other imaging techniques, it will appear as if there are multiple cysts. So you must rule out obstruction of the urinary tract before confirming this is a cystic disease. And tissues types sponge because of very small tiny system and they being many in the medullary uremic dialysis cystic. So you will also keep in mind that when a patient is under dialysis, those who have a renal failure, impyiko zabo zitagikora bakabafasha babaha uburyo bwo filitra amaraso kugira ngo badapfa kubera ko urea n'ibindi byose they are toxic, they must go out from the blood stream. Niyo mpamvu umuntu ufite renal failure agomba kugira dialysis kenshi. So imwe muri complications of dialysis then it is to have to develop a cyst within the kidney. That is known. But of course, it doesn't develop in everybody and it is less harmful than the failure itself because the renal failure, it is deadly. If nothing done, the patient dies. So, that in shrink kidneys and also. So then, from that, we continue with the data and the acute one. As I saw on the table of content, the chronic renal failure will come afterwards. Gusa icyo nazivugaho acute renal failure birumvikana nije vuba vuba akenshi bitewe n'ikintu ki obstruction kandi ibintu bitera akenshi bishobora kuvanwaho umuntu akongera akaba normal. So uzasanga ari umuntu wagize ibimenyetso ko afite renal failure ariko ije vuba nta bundi burwayi yari asanganywe bamujyane kwa muganga. Ikintu kizihutirwa ni ugukora dialysis kugira ngo ibintu biri toxic bitamuhitana, hanyuma bashaka impamvu yari hari, niba yari obstruction or another reason. Niba yikuraho umurwayi azakira atahe amere nk'abandi basanzwe. Ariko chronic renal failure it is not possible because it is usually related to diabetes or hypertension or other causes which are long standing. So yo uzasanga ikibazo ni damage on the glomerular. While for acute one, it is not a damage to the glomerular, it is obstruction somewhere. So then for chronic renal failure, nta kindi kizashobora kuba ko glomerular they are damaged, you cannot repair them. So either you do dialysis and you do transplantation. So kuri acute renal failure gukora dialysis no kumufasha gusa, otherwise when you have found the cause and you correct it umurwayi arakira. But for chronic renal failure ngana kuri hypertension yabiteye cyangwa ikindi nubwo wamuha imiti hypertension, it will not reverse the damage on the glomerular. That's why you have to replace which is not good umurwayi azaba ukora kwa muganga wenda bakora dialysis gatatu mu cyumweru and so on, kandi it is very expensive. It is very expensive. Na mituweli nko mu Rwanda izikomeye ntabwo niyo kumare zemera gukorera umuntu dialysis ngira ngo ni gatatu cyangwa kabiri gusa, kuko bo bashaka ko gukavaringa acute renal failure niyo bakavaringa. Chronic one they don't. So to be sure that they don't miss, then bemera ko buri wese akorerwa dialysis, ariko barayizibara iba imwe zikaba ebyiri bahagararira. Ubwo ibindi babyita chronic, umurwayi ntabwo bakemeye kuyimukorera. And each session is expensive, of course. So the best way then it is to do renal transplantation, guhindura ku muntu agabwa kidney yahawe n'undi. And this is actually, it was supposed to start in Rwanda this month at the King Faisal Hospital. In the next 2 months, it will start. Of course, it's a bit byinshi, imyiteguro and so on. That's why it has taken time. Otherwise, murabizi ko abantu benshi bajyaga hanze kubikorera hanze. And it requires operation in the donor and the operation in the one who receives the kidney. You can understand that. So you must make sure there is a compatibility, cyane compatibility y'amaraso ariko na compatibility ya human lymphocyte antigen HLA bagomba kuba bihuje, otherwise antibodies z'umuntu wakiriye kidney umubiri uzafata ya kidney nshyashya nka foreign body, so ishwanyaguzwe na za antibodies and T lymphocytes and so on. So that's why they try to find a good match for the kidney transplantation. Nubwo kandi wabona match bahuje izo groupe wenda banagira icyo bapfana cyafi, ntabwo bivuga ko n'ubundi hatabaho a graft versus host reaction. N'ubundi umuntu bamuha imiti igabanya immunite ye, harimo steroids, corticosteroids, which are immunosuppressant, kugira ngo immunite y'uwo muntu igabanura ingufu ye kubona akagufu ko kurwanya the new kidney. So, but when you read it in the literature also, it says when a kidney is well tolerated, when bikakara ko yamaze gufata nyuma y'ibyumweru cyangwa amezi nako yafashe, n'ubundi bivuga ko iyo umuntu ahawe kidney akiri muto ntabwo ashobora kuyimarana imyaka irenze 20. So bivuga ko umuntu ahawe kidney sincere agomba kuyifata neza, it is precious, ashobora kubura burundu undi uyimuha, agomba kuyifata neza, ariko nabwo na yakiri muto akarama indi myaka igera kuri 20 byanze kunza agomba gufata indi kidney. So methode zo guhabwa kidney, hari guhabwa kidney y'umuntu muzima birumvikana, hari na kidney zitangwa na nk'umuntu akaraga akavuga ati giye kidney zanjye ni imfa, muzazifate muzibike hanyuma muzaziha umuntu yikeneye, muzayiha umuntu yikeneye. Ibyo bibaho. So bibaho, ariko consequences zibamo nuko kidney y'umuntu wabanje gupfa cyane cyane narupfire kwa muganga leta bayikuramo biroroshye, ariko yabanje kumara igihe ifite ischemia, itabona amaraso na oxygen, n'umuntu igihe yapfuye mu gihe batarayikuramo, nubwo wayiha umuntu risk zo kudafata rejection ziba ziriyongera kurusha iyo umuntu uri live. Ikindi kandi niyifashe kurama kwayo muri wa muntu ntabwo ari kimwe n'uwahawe kidney ivuye mu muntu ukiri muzima. So mu gihe navuze ko ukiri muzima, kidney watanze kidney akiri muzima, kidney ishobora kumara imyaka itarenga 20 mu yayihaye, ya yindi yavuye mu muntu wapfuyeyo ishobora kumara imyaka 12 cyangwa 13 ntabwo irenze aho ngaho. So I think all of this will be explored while setting up the kidney transplant in Rwanda, but ntabwo wava ngo umuntu azihitiramo ngo hagati y'ibyo, kubera ko haba hari list, ibihugu bimenyereye gukora renal transplantation, haba hari list ndende ku buryo umuntu ashobora no kumara imyaka 3 ategereje kubona kidney which matches him or her atarayibona. Niyo mpamvu iyaboneka yose barayimuha, kuko uko byagenda kose kidney guhabwa transplant nibyo bitanga result nziza kurusha guhora kuri dialysis. So dialysis umuntu aba ari dependent no guhora kwa muganga kenshi ari kuri machine, mu gihe transplant iyo maze gufata umuntu abanyana agakora nk'abandi basanzwe nta bindi bibazo. So the basic principles about the acute renal failure. So it can be intrinsic, meaning that there is a damage within the structures of the kidney, and that damage was initiated maybe by the body itself, maybe autoimmune diseases. There is a pre-renal causes of acute renal failure. Ni ikintu cyose cyatuma amaraso agera mu mpyiko aba makeya. Ibi bikunze kubaho nk'iyo let's say habayeho thrombosis within the renal artery, birumvikana amaraso agera amazahita agabanuka. In that case umuntu azagira acute renal failure. Ikindi ni post-renal obstruction of urine outflow from the kidney. So habaye obstruction ureter and so on, urine zika damage ahangaha. Usaka ko iyo bikiri acute biroroshye ko organ damage bikiri nkeya ku buryo uko obstruction umuntu yongera kidney zongera zigakora nta kibazo. So this is actually a severe decrease in renal function, and this develops within days. Wenda ikindi nshaka kuvuga ntabaguhanga neza kuvuga gatatu nuko kugira ngo umenye ko umuntu wari ufite renal failure cyangwa se n'uwari uri muri shock yayiguyemo nuko azana urine nta n'ikindi. Igihe cyose utabaye umuntu wari uri muri shock na koma ukabona atangiye kuvamo akakuvugisha na serum wamuhagaze azagenda ukazagarika ukamuha ibyo kunywa bisanzwe n'ibyo kurya ukabona ameze neza. Igihe cyose urine zitaraza ntabwo uwo muntu ugomba kumurekura ngo avaho ngaho until the urine come, then you can't confirm that you have relieved the issue. So the hallmark of acute renal failure is azotemia. So blood increased, and uriguria, and sometimes anuria. Anuria no one, there is no urine at all. Uriguria, there is little urine. So muzabona kwa muganga bafite ukuntu bapima urine umuntu yasohoye mu gihe cy'amasaha 28 hari ahantu bashyira bakapima bakareba. So there is a normal volume according to the age of each person. So iyo bitagezeho rero iri munsi kwahita origuria, iyo nta na gace kaje ni anuria. So and as we see there is a azotemia. So azote ibiri muri bya urea. So niyo mpamagaza yo na mu bizame bya mbere no cyane mu urea. So iyo urea izamutse cyane biba bisanzwe ko somewhere the kidneys are suffering, and creatinine also. So they are divided into prerenal, postrenal, and the intrarenal azotemia based on its urine. So this is what I was explaining with this diagram. So prerenal azotemia. So and this diagram is general. So I'm going to try to finish but it is talking about these three types of acute renal failure. So prerenal azotemia is to decrease blood flow to the kidneys, such as in the case of cardiac failure, and this is the most common cause of acute renal failure. So, and here there are other causes: burning, burns, hemorrhage in the gastrointestinal tract, shock and stress, and dehydration. So all these can cause azotemia of prerenal type. So the decreased blood flow will cause the decrease in the glomerular filtration rate with azotemia and then little urine. So reabsorption of fluid and the blood urea nitrogen ensures kubera ikintu kuvuga za deshe zari kumanuka muri urine, kidney zawe ikindi ikora yongere izikwe reabsorption zisubire mu maraso, ariyo mpamvu bizazamuka muri serum. So the blood urea nitrogen to creatinine ratio will be more than 15. So the tubular function remains intact. So tubules are intact. The problem is at the glomerular filtration. But the fractional excretion of the sodium is than 1%, and the urine osmolarity will be high. So urine needs another very constant. Ziza ukabona nta nubwo ari umuhondo gusa ahubwo zishaka kuba brown. So when the urine is too much concentrated, it has high so fraction excretion of sodium also it will be low. Kubera ko sodium itari kumanuka muri urine. So for postrenal azotemia, so here in ratio when it is so high, what refer to? So I'll just finish to read. So the postrenal azotemia, as we said, it is when there is an obstruction below the kidney. So maybe from the calces up downwards. So up to ureters and so on. So there will be decreased outflow, which will result in a decreased glomerular filtration rate azotemia and oliguria again. So during the early stage of the obstruction, there will be increased tubular pressure forces, which forces the blood urea nitrogen into the blood. So ngira ngo birumvikana mu gihe filtration yagabanutse, izagabanuka, azotemi izamuke, ariko azotemi izazamuka kubera ikintu ko urine muri tubules they will be zaba oblige yo kuongera kwa absorba urea. So there is no this ratio will be again high. So, but the tubular function remains intact. The osmotic urine will be too much concentrated. So with long-standing obstruction, tubular damage will ensure. So nuko ko urea n'ibindi bintu biri muri urine yabuze kwitambuka ngo imanuka asige ijyanwe hanze, bizakora damage kuri tubular epithelium, and it will be damaged, and therefore the function of the tubules will be also compromised. So, and in such cases, there will be decreased reabsorption for blood urea nitrogen, and you will see it in the blood, in the serum, whereby now the ratio will be less than 15. So ibi bivuga ko mu gihe uri gukurikirana umurwayi bwa mbere ukabona iyi ratio iri hejuru ya 15 urea nitrogen to creatinine, cyangwa se urea ugereranyije na creatinine hejuru ya 15, azaba akiri muri early stages. Nyuma nubona byahindutse ukabona no ratio yagiye hasi ya 15, bizaba bisobanura ko tubules have been damaged or are being damaged. So therefore measures should be taken at that stage, kubera ko you may lose that patient. If tubules are being damaged, then it is easy for that patient to be lost. That's why we have to intervene. So, of course, what you process. So I think you can remember what you saw in cell death and cell injury and so on. So these tubules have died. You cannot any longer see here what was the cell, where was the cytoplasm, which was the tubule. No, everything is here is necrotic. Of course, also it is necrotic, but it is at least you can see its contours. But the tubules are necrotized. So there is injury and necrosis of tubular epithelial cells seen here. Most common cause of acute renal failure. So it is one of the causes of renal failure. Amahirwe nuko is the tubules, they are lined by an epithelium, so the epithelium which is rabide, so they can be replaced by others. Ariko icyo gihe bibaho aruko epithelial cells zitashize zose, or if their precursors are still alive, so they can be replaced. So necrotic cells will plug the tubules. Nukuvuga zizaba necrotized, zizamanuka aho tubule ikiri nzima zigenda zifunge ku buryo ni na tubule zari zikiri nzima, at the end they will be obstructed. So the obstruction will decrease the result will be cast in the urine. So muzabona kwa muganga bavuga ngo twabonyemo cast cyangwa bakubaze harimo cast, ni ikibiza bivuga. The just necrotic cells which come down through urine. So ni bisanzwe ko these epithelial cells they are rabide, so zigenda zisimburana, hari zihunguka exfoliated zikamanukana na urine, ariko iyo zije ari utubumbe twazo kandi which are necrotic, it shows that there is a tubular necrosis somewhere. Otherwise kubonamo izamanutse muri urine zitari necrotic ni bisanzwe. So dysfunctional tubular epithelium will result in decreased reabsorption of blood urea nitrogen. Yeah, they show ya nitrogen creatinine zabiri hasi. decreased reabsorption of sodium, and the inability to concentrate the urine. So here, the urine will be kugira ngo yiconcentre urine nuko amazi yabaga reabsorbed aba menshi. So iyo ayabaga reabsorbed yabaye make, muri urine zikaza zirimo amazi menshi, concentration iramanuka. Ikindi kibitera ni decrease the sodium. Ngira ngo ni rule abantu bavuga nanjye neza bivuga ahantu hose hagiye sodium niho hajya amazi. Niba rero umuntu atagize iyi absorption of sodium kuko yari kujyana n'amazi gasubira mu maraso, bivuga ko bizamanukana muri urine. Therefore urine will be not concentrated, so there will be few urea and so on. So this was acute tubular necrosis, and it continues here. So the etiology may be ischemic or nephrotoxic. So ischemic, you understand, nephrotoxic is something which can be toxic to the tubules. And so on. So ischemia, this is, as you know, decreased blood supply, which will result in necrosis of tubules, often preceded by prerenal azotemia, and proximal tubule and the medullary segment of the thick ascending limb are particularly susceptible to ischemic changes. So they are the proximal tubules and the medullary segment of the thick ascending limb of the nephron. They are the most areas which can be easily affected by these ischemic changes. So for nephrotoxic etiology, there are toxic agents which result in the necrosis of tubules. So ni ibintu byinshi n'ubundi proximal tubule niyo ikunda kugira ikibazo aha ngaha, but they include aminoglycosides. Iyo ni imiti, of course, heavy metals, lead ngira ngo niyo bita plomb mu Gifaransa, myoglobinuria, sorry. Myoglobinuria ni protein ikunda kuza muri which have been destroyed. Ibikunda kugaragara ku bantu bahiye, kubera ko iyashya yahiye uruhu akenshi bifatana amasazi nazo zigashya. So when they are burnt, then they produce this myoglobin, which is very toxic. Niyo mpamvu uzasanga umuntu muri yahiye bakurikirana cyane kidney function, bahore bapima urea, creatinine, bashaka kureba niba iyo myoglobin itamaze gukora damage kuri kidney. That is the explanation. Another cause is the ethylene glycol associated with exarate crystals in urine. Radio contrast dye no kuvuga biriya bintu batera umuntu bagiye kumukorera CT scan cyangwa X-ray kugira ngo produce contrast, njyamo nawe so bituma ahantu hagaragara nko hari opaque, ukabona ahantu hari yifunze n'ibindi. So, but these products, they are dangerous. Niyo mpamvu nta gihe na kimwe bashobora kuzitera umuntu batanje kureba niba kidney ze zikora neza. So they are dangerous but helpful. Niyo mpamvu umuntu adashobora kureka kubikoresha, ariko basanze kidney zifite ikibazo, there contrast will not be used. So ntabwo rero nubona usabiye umuntu imaging with contrast bakakubwira ngo banze ukore urea, creatinine, uzamenye impamvu. That's the reason. Hydration and allopurinol are used prior to initiation of chemotherapy to decrease the risk of urate-induced acute tubular necrosis. So umuntu wese ugiye guhabwa chemotherapy, iriya miti ya kanseri ikomeye n'indi yose ikomeye, agomba kuhabwa baha serumu, so kidney za kwangirika. So it is like a prevention. So acute tubular necrosis. So the clinical features will be oliguria with brown granular cast. You remember this granular cast, just the mibumbe ya necrotic cells. Elevated blood urine nitrogen and the creatinine. Hyperkalemia due to decreased renal excretion. with metabolic acidosis. So I think this you saw in the physiology and the pathophysiology, the relationship, this during acidosis or alkalosis and so on. So this is the agglomerated. What the reasons may be that there has been tubular injury and then obstruction here, and with this obstruction the filtration which took place nicyo twakwita urine cyari cyakozwe hano kizabura kinyura bizagaruka hejuru bitume then guhomerera nyuma yirekera mu gukora akazi kayo. So acute tubular necrosis is reversible, but often requires supportive dialysis since electrolyte imbalances can be fatal. So acute tubular necrosis, acute renal failure, birumvikana kugira ngo urinde ko umuntu apfa ukora dialysis. Otherwise, this will be reversible because the cells here damaged are labile cells, so can be replaced by other cells very easily. So oliguria can persist 2 to 3 weeks before recovery. Tubular cells, these are the ones that are stable, are not labile. Can take time to enter the cell cycle and regenerate. So that's the reason. So they are not labile, they are stable. So they can divide when there is a need. So apart from acute tubular necrosis, we have also what we call acute interstitial nephritis. So ahangaha ni murabizi muri kidney dufite glomeruli tukagira na tubules, but around them we have blood vessels, we have interstitial tissue. So when there is inflammation in that interstitial tissue with vessels, nicho bavuga so it is like the nephron framed, but specifically its interstitial ntawe itandukanya na vascular channels in the kidney, so they form the same unity. So this is usually drug-induced hypersensitivity involving the interstitium and the tubules, and that's why there is this word nephritis. Otherwise, you require interstitial nephritis, interstitial inflammation, but because the tubules are involved, also this word nephritis is added. So for I think the history, this you can recognize. This is a tubule, this is another tubule, and here there was a tubule, and here there is another one, a smaller one. Yeah, so the area here in between is interstitium, where we have just inflammatory cells, many lymphocytes here. So probably this is a medulla. We don't have a glomeruli here. We are not seeing them. So this results in acute renal failure. What twabonye irimo amoko menshi, and this will be of intrarenal azotemia type. When you post-renal, pre-renal, and then intrarenal azotemia. So if now this acute interstitial nephritis results in the acute renal failure, it will be of intrarenal type. So the causes include non-steroidal anti-inflammatory drugs, such as aspirin, ibuprofen. The drugs we use for antibiotics is in a comment and next one of those also. And the drugs which are given to someone to help him to form urine and to urinate. So these are diuretics. Uzajyamo nabazwa umuntu wagize edema cyane cyangwa se ugira congestive heart failure amazi so ibijyanye na edema imigenero akunze kuziba, cyangwa se umuntu wagize ikibazo cya kidney zitari gusohora urine, so barayimo iyo miti kugira ngo asohore urine, and then urea imanuke, toxicity mu maraso igabanuke. So they present with oliguria, fever, rash, fever because it is inflammation, rash days 2 weeks after starting a drug. So rash is nk'amaheri yareresha atewe na resha. So eosinophils may be seen in urine. You know, eosinophils, they are anywhere there is a parasite or allergy. So, and this disease will resolve with the cessation of the drug, but if not, it may progress to renal papillary necrosis. So, no, so this is the kidney cortex, and here we have I call them caryces, and their papillae are here. So this papillae can be necrotized. So this is the pelvis, and then the ureter coming from there. So this is showing the renal necrosis of the renal papillae. So, and this will present with gross hematuria and flank pain. Flank ni kwa kidney kuri flank niho haco hagana inyuma mu mugongo hejuru. And so, because if necrosis is here, umuzabona umuntu afite gross hematuria, donc amaraso bisa naho ari fresh, nicyo ushaka kuvuga, kandi ari menshi ku buryo muri urine uzabibona ko zitukura. While when it is not gross, kwahita microscopy. Ni igihe kuri microscope ariho honyine babonye ko harimo red blood cells, maze bita microscopic hematuria. So the causes will include chronic analgesic abuse. Abantu bafata imiti irinda igabanya uburibwe kenshi wenda bitanaye ngombwa ngo bashyizemo ijambo abuse, nk'abafata phenacetin, abafata aspirine igihe kinini, they cause damage there. Diabetes mellitus is another cause, sickle cell trait or disease. So sickle cell abantu bafite hemoglobin abnormal hemoglobin S, harabayigira nka trait, ni ukuvuga afite ikibazo. So bizwi ko ufite arere imwe ari nzima, indi ifite ikibazo ya hemoglobin, n'ubundi hari utumenyetso tumwe na tumwe twa sickle cell disease bagira, niyo bavuga ko bafite sickle cell trait. Iba disease noneho iyo both alleles, when both alleles are affected. So other causes are severe acute pyelonephritis. So it means the pyelo refers to the pelvis. So there is the inflammation of the pelvis. And the acute pyelonephrosis. This is one of the causes of sudden death. So that's so far what we can say about this acute renal failure. So before going to the another syndrome, now nephrotic syndrome, if you have questions, you can ask them. No questions? Okay, so we can proceed then. So proceed to the nephrotic syndrome. So I have put the emphasis on this O because we have a nephritic syndrome afterwards. So nephrotic syndrome and nephritic syndrome, they are very different conditions. So in a nephrotic, ikintu cya mbere uhita ugomba kumvamo nuko hari protein zimanuka muri urine. Now nephritic, it is just inflammation. Usually muri urine hazamo amaraso. So nephritic syndrome can have hematuria, and it is always inflammatory. While nephrotic syndrome, there is a loss of proteins through urine. So basic principles. So the this is one of the glomerular disorders characterized by proteinuria. So the loss of proteins within the urine, more than 3.5 gram per day. So iyo ikiri hasi aho ngaho ushobora kuvuga ko umuntu afite proteinuria ariko ntabwo uhita uvuga ngo umuntu afite nephrotic syndrome. Kubera ko iyo bivuze ni ikintu gikomeye, ntabwo ari ikintu cyo gupfa kwemeza gusa. So ugomba there are conditions for which on which you can base yourself in order to confirm that it's a nephrotic syndrome. So they are characterized by hypoalbuminemia. I think I explained this when in general pathology we saw hemodynamic changes that uburyo glomeruli zacu ziremye nuko nyine zifite pores ahanyura fluids zizavamo urine n'ibindi. Izo pores ni ntoya ariko albumine izirutaho gatoya. Albumine izirutaho gatoya ku buryo habaye ikibazo na gitoya kuri izo pores zikiyongera size yazo albumine itakara muri urine. So niyo mpamvu ariyo ya mbere igenda, niyo proteine ntoya dufite mu maraso, so itakara kandi n'izindi zishobora gutakara, ariko yo impamvu itabigaragara nuko ari igenga osmotic pressure. Then when it is lost, blood pressure will decrease with consequences as we saw in edema and so on. So there is hypogammaglobulinemia, meaning that gamma globulins will be also lost, and because this, as you know, they are important also in fighting infections. Then these people, they will have increased risk of infection. Hypercoagulable state due to the loss of antithrombin 3. Antithrombin 3, it is a protein which is also important to fight against the blood clotting. Pako thrombin nko mubizi ituma habaho blood clotting. So antithrombin then it is against blood clotting. So hyperlipidemia and hypercholesteremia may result in fatty acids in urine. So hari ibintu bitatu biranga umuntu ufite syndrome nephrotic syndrome, harimo gutakaza urine, gutakaza protein muri urine, harimo kugira edema, hakaba kugira hyperlipidemia. Ibyo bintu muri rusange, ibyo bintu bitatu nibyo biranga abantu bafite nephrotic syndrome. So and here they say the edema will begin on the face, azatangira kubyimba mu maso. Mu gihe umuntu ufite edema yatewe n'ibibazo by'umutima, we kubyimba kwe bizatangirira ku maguru n'ahandi muri periphery, ariko ahangaha iyo ari ikibazo cya nephrotic syndrome bitangira mu maso. Pale skin with fissure, tachycardia, vomiting, proteinuria, of course, and the hyperlipidemia. So these are the findings. So nephrotic syndrome rero igaragazwa n'ibintu byinshi, nibyo tugiye kureba. Kuko nephrotic syndrome is not a disease, ni uruhane rw'ibimenyetso bishobora kuranga indwara nyinshi zitandukanye. Niyo mpamvu iyo ubonye umuntu ayifite ugomba gushaka izo ndwara ubwazo, kuko niba uzamuvura etiologically. So nk'abaganga ntabwo mugomba kwishimira kuvura umuntu ibimenyetso, ahubwo kuvura uburwayi, impamvu yateye iyo ndwara whenever possible. Of course, usually you start by supporting that person through symptomatic treatment, but at the end, as a medical doctor, you must find the cause and treat the cause. Otherwise, so one of the causes of nephrotic syndrome, it is what we call minimal change disease. So bayita minimal change kubera iki? Nuko kubera ko irebye kuri histology ntabwo ubona changes. You don't find any abnormality. Abnormality uyibona iyo ugiye kuri electron microscope. So ngira ngo mbivugira hanga ibintu bikorwa mu ndwara za kidney ndetse n'iz'uruhu, izijyanye na antibodies n'ibindi nk'ibi, nuko ukora histology, ugakora electron microscope n'ibyo bita immunofluorescence. So immunofluorescence, we shall see some diagrams or pictures. You just send some antibodies to a tissue, and when those antibodies maybe react with something there which you targeted, it will become positive. Izana urumuri rushashagira, niyo mpamvu harimo ijambo fluorescence. Kuri microscope, ntabwo ari microscope zisanzwe zibisoma, ni nke cyane. Mu Rwanda hashobora kuba hatari n'eshatu, so zishobora kubisoma. Nibwo none icyo gihe uravuga uti cya kintu nashakaga kuko kirimo, because I targeted it and it became positive. So nibwo buryo butatu bukoreshwa: immunofluorescence, electron microscopy, and just the histology. And histology in minimal change disease will not help. It will show now abnormality. And they say that in minimal change disease also immunofluorescence will be negative. You will find nothing abnormal. But electron microscope will find something. It will find effacement of root processes. So biranumvikana immunofluorescence ubundi iba positive iyo hari deposits, immune complex which are deposited somewhere. Ariko ahangaha muri minimal changes there is no deposit, nuko gusa processes of the mesangial cells have been destroyed. So if these are mesangial or epithelial cells, ubundi haba ari processes nyamwabyuka kuri histology, bari ibintu bimeze nk'intoki bigenda binyuranamo aho amaraso cyangwa fluid inyuramo hagati, kaba filtered, bigomba gufatwa bigafatwa, noneho amazi y'agaso akakomeza akamanuka, and some minerals. So when then you have lost these processes, ni ukuvuga ko hari na protein bwazo zamanuka n'ibindi bigenda, kwa ko izo food processes nizo zabifataga zikabigarura. Ni nk'akayungiro turatuntu tumeze gutudodo turamutse ducitse mu byose birahita. So these processes, food processes, they are not seen on the right microscope. You can only see them under electron microscope. So when then you have diagnosed this, you give steroids which are anti-inflammatory, the patient will recover very quickly because the damage was mediated by cytokines, and these cytokines are from T cells. By giving steroids, now you suppress the function of these inflammatory T lymphocytes. So a second category of diseases causing nephrotic syndrome is focal segmental glomerulosclerosis. So harabara amagambo agomba kwitonderwa. Glomerular sclerosis, it is like a fibrosis, as you remember. So if you see this glomerulus, igice cyo hejuru ntabwo gifitemo ibintu biri brown or pink like this one. So these brown or pink things, these are deposits. They are fibers and so on. Bita sclerosis. So bayita segmento yo kubera iki? Nuko glomerulus yose itafashwe, igice kimwe cya glomerulus nicyo cyafashwe, niyo bayita segmento. Focal yo ivuga ko glomeruli zose ntabwo zazafashwe. So focal, it deals with the number of glomeruli. So not all glomeruli are taken. Whereas segmental deals with if in one glomerulus which is affected, is it entirely affected or not? So when it is affected in a part, we call it segmental. And these descriptions are very important because utadekrive ko bigomba, then bagatanga diagnosis itari yo kumuvura, bazavura ibintu bitari. Niba afite focus segmental, wo ukayita ko wenda ari global, ari generalized segmental, bivuga ko ni all glomeruli, but each glomerulus being affected partially. Icyo gihe uko babivura biratandukanye, ngo ugomba kubyitondera. So this may be for us pathologists, of course. And also you should do, when we interpret as such, you should do take care of the terminology we have used. Otherwise you ubyumvise nabi, kumva segment ukumva ko ari igice kimwe cya kidney naho kumva ko ari igice kimwe cya glomerulus, ushaka kumuvura mu buryo butari. So I hope some of you will be nephrologists, meaning those who are specialized in treating these kidney diseases, the non-surgical kidney diseases. So far we have a few nephrologists in our country. Ntabwo ntekereza ko bageze kuri batanu. The most common cause of nephrotic syndrome in Hispanics and the African Americans, so abirabura bo muri Amerika ndetse n'abari abantu baba Hispanic, so bari abantu babona abanyamerika y'epfo bamwe za Mexique n'ibindi bihugu bya Venezuela, bafite ukuntu bameze, ntabwo ari abazungu buzuye, nta nubwo ari abirabura, so that's why bakunda kubashyira ukwabo Hispanics. Usually idiopathic, meaning that the cause is not known, may be associated with HIV, heroin use, and sickle cell disease. So these are like some assumptions or just the risk factors which are known. Ariko inshuro nyinshi ntabwo uzi exactly what caused that disease. Focal, as I said, it is for some glomerular and segmental involving only a part of the glomerulus. So this is what I was explaining. Sclerosis on H and E, hematoxylin and eosin. And when you go to electron microscope, you will see effacement of food processes, and on immunofluorescence, there will be no immune complex deposits. So ni ukuvuga ko ijya gusa n'iriya twabanje hejuru, iriya minimal disease change, nuko minimal disease change yo kuri light microscope nta kintu ubona kidasanzwe. Naho ahanga urabona ko harimo sclerosis, there is effacement of food processes, ariko nawe nta immune complex deposit afite, niyo mpamvu immunofluorescence ari negative. So ngo electron microscope ntawe navuze mu Rwanda ntawe dufite, nta nigeze haba kugeza ubu mu Rwanda rwabaho, so probably it will be there here in future, ariko ibihugu duturanye hari ababizifite. So it is important. Ntabwo ikoreshwa muri diagnosis kenshi, ariko ahantu igira umumaro munini ni muri izi ndwara za kidney, non-surgical disease of the kidney, mu ndwara z'uruhu, non-surgical disease of the skin, and then it is also very important in viruses. Therefore, virus ntabwo ibonwa na light microscope. So although we are about to start the kidney transplant, but without it, we will have some limitations. Gusa ahenshi aho ikenerwa dushobora gukoresha immunofluorescence, ariko murabona ko immunofluorescence hari aho iba negative kandi electron microscope ikerekana ikibazo. So that is a challenge we have. So probably what we shall do in this case, we shall be sending the specimens abroad for diagnosis whenever we need electron microscope. So waiting for having it in our country. So this disease, it doesn't respond well to steroids. Nk'iriya twabanjeyo twabonye ko minimal disease change yo y'umuhaye steroids barakira vuba, but this is not, because when there is sclerosis, it is fibrosis. It is not easily reversible. It is not reversible. That's why usually these patients, they will progress to chronic renal failure. So bivuga ko ubundi ikindi ntavuzeho ahari muzabyiga muri nephrology cyangwa mwarabyise, nuko umurwayi ushyize kuri ukore transplantation, bibaye byiza wayikora ataragira renal failure ngo agire aho akenera dialysis, ko byagaragara ko uhabwa indi kidney atarakorerwa dialysis na rimwe biba byoroshye ko kidney ifata vuba kandi igakomeza kuba healthy kurusha uwabanje kugira these other challenges. So bivuga ko nk'indwara, if you diagnose it, because you know it will progress to chronic renal failure, better now if you are able to do renal transplantation before sending the patient to dialysis whenever possible. So another condition causing nephrotic syndrome is membranous nephropathy. So aho haza ibimambrane biza muri glomerulus, aho filtration yari kubera bikaza bikaharyana. So ni nkuko afite akayungiro hakaza nk'ikintu cy'igishashe kikajya. So ntago zaba bishoboye kuyungurura. That is the meaning. So these glomeruli, then these membranes are coming from what? So I think nicyo wakwibaza. So first of all, this is seen in Caucasian adults. So ngira ngo izi ndwara uko ari eshatu, hariyo twabonye yiganje mu bazungu, hariyo twabonye yiganje mu Hispanics, nako mu birabura, mu Hispanics. Now this is more common in whites. Usually idiopathic may be associated with hepatitis B or C, solid tumors, systemic lupus erythematosus, drugs such as penicillamine and non-steroidal anti-inflammatory drugs. So they will have on histology, hematoxylin and the eosin staining, they will have a thick glomerular basement membrane. Kubera ako gashashi kiyongereho, iyo membrane yongereho. This is due to immune complex deposition. Byumvikana impamvu immunofluorescence none bizaba positive. Immunofluorescence no kwisa harimo utuntu tw'icyatsi kibisi. So ahantu utuntu tw'icyatsi kibisi twabaye broad cyangwa twabyibushye ni ko hari immune complex deposits. And on electron microscope we have a deposit ibintu by'umukara birimo hano bikurikiye. This is a filtration area, so ibintu by'umukara biri hano, they are deposits. So and these are the ones which are detected by immunofluorescence. So also they don't respond to steroids, also they will progress to chronic renal failure. So bivuga ko minimal change niyo yenyine ishobora kuba reversible. Otherwise the focal segmental glomerular, it will not be reversible, and the membranous nephropathy also will not be reversible. So there is another one called the membranoproliferative glomerulonephritis. So hariya membrane twabonye muri ndwara itambitse, ariko hazamo na proliferation of mesangial cells. So muri mesangium amasero uko mwagiye muri histology agomba kuba ari abiri per group, per each group agace gato ka mesangium. So iyo abaye menshi tubyita ko habaye proliferation. So that's why here they call proliferative glomerulonephritis. Membrane, so there is a membrane, a deposit of immune complexes, but also there is a proliferation in the mesangium. So combining all this, and they are seen not only in the glomerulus but also in the nephrons, tubules. That's why it will have such a name. Thick glomerular basement membrane, thick because of the membrane, often with tram track appearance. Due to immune complex deposition, and this will have a granular appearance on the immunofluorescence. So we have two types. Type 1, it is subendothelial. When the deposits are under the endothelial cells in the glomerulus, or the type 2 intramembranous associated with complement 3. Hope you remember this in inflammation. So ahangarero no koresha antibodies which detect complement 3, it will be positive. That is the meaning. So this is type 1 is associated with people who have hepatitis B virus or hepatitis C virus. So they don't respond to steroids, they progress to chronic renal failure. So nkuko mubibona indwara nyinshi, inshuro nyinshi umuntu afite nephrotic syndrome, it will progress to renal failure, unless it was minimal change disease. So another condition which can cause nephrotic syndrome is diabetes mellitus. This is because high serum glucose leads to non-enzymatic glycosylation of the vascular basement membrane, and this will cause hyaline arteriolosclerosis. So hanga harimo utuveso dutoya, small vessels, but which are thick-walled. So a thickness is increased as compared to the normal one, so that's why they call arteriolosclerosis. So and it is said that the efferent arteriole is more affected than the afferent. So is the arteriole nukuvuga hari izana amaraso ngo ayungururwe niyo afferent. Ifata amaze kuyungururwa ikayajyana niyo efferent arteriole. So then the efferent one, the one having the filtrated blood, is the more affected one. And this causes glomerular filtration pressure. icyo bishaka kuvuga nuko filtration irakorwa kubera ko glomerulus it is normal in this case. Glomerulus is normal, but because the post filtration area is damaged, that efferent arterial, because it is damaged, then amaraso agomba gukomeza ntabwo azakomeza, ariko filtration izakomeza noneho ishyire pressure kuri efferent arterial. That's why there is this word pressure, filtration pressure. This will progress to nephrotic syndrome, usually characterized by sclerosis of mesangium with formation of Kimmel-Stier-Wilson nodules, which I was showing here. So angiotensin converting enzyme inhibitors will slow the progression of this hyperfiltration induced damage. So bivuga ko uzi umuntu ufite iki kibazo ukamuha imiti bishobora kumufasha kutajya damage no kutagira nephrotic syndrome. So another condition is systemic amyloidosis. You remember amyloid, you saw it in the first chapters of general pathology. This amyloid muziko okay, muri wacu ukora amyloid ni ubusanzwe, ariko hari igihe habaho abnormal proteins. Kubera ko muri catabolism of them haba ari ahantu hari indike enzyme iza ikazicamo. Iyo rero ikoze nabi enzyme igasanga aho ugomba guciramo ntihari cyangwa himuriwe ahandi ntabwo ibikiri bikoze, bituma rero ziba deposited because they cannot be digested and processed. So they will be deposited. But there are many other reasons. When there is a chronic inflammation, we have too much deposit of normal, what you can call normal amyloids. Abantu bafite some neuroendocrine tumors, they form a lot of proteins, among which we have amyloids. So now coming to the kidney, this amyloid will be deposited in the glomeruli. Usanga zitukura cyane, they are pink on hematoxin diosine. It is what is being shown here. You can see that on this area there are mesangial areas, they are larger than in this part. So because of the deposits and so on. So to confirm there is a amyloid, hari ibyo bita birefringes. Ni ukuvuga uko uhindura microscope za objectives and so on, you polarize the light, uzabona hari kuzamo urumuri rimwe rutukura ubundi rukaba icyatsi kibisi. Green birefringes, apple green birefringes under polarized light microscope after staining with Congo red. So Congo red is a special stain we do in histology. So then once you have seen this, you will know the cause, and if you can treat, you will treat. Ikibazo hari ubona ko amyloid ariko ntumenye ahantu yaturutse, nicyo kindi kibi kibazo kugira ngo ubashe kumuvura. So ariko akenshi iyo habayeho deposit of amyloid is very toxic. It destroys many things including neurons. Niyo mpamvu muzabona abantu bakuze bibagirwa, nuko amyloid k'umuntu akagenda agira za amyloid ziba deposited ku bwonko zikangiza neurons, kandi neuron idasimburwa, so akagenda ata ubushobozi bwo kwibuka akibagirwa. So I say this just to explain that it is not easy to make these things irreversible. So I think these are like 6 or 7 diseases which are associated with nephrotic syndrome. Ariko rero nubwo bimeze gutyo, nubwo hari inyinshi zikomeza zikajya kuri renal failure, and ntabwo ari buri gihe. So I remember a case I think it was like my second or third case I published when I was a resident. So yari umurwayi wari ufite nephrotic syndrome, but it was not easy to know the cause. So they took a biopsy, then we examined it. We found this focal segmental glomerulonephritis. So now ikibazo cyari kuvuga ngo byatewe n'iki. So when they went back examine and so on, that was special stains we could do, we see that there are deposits in the basement membrane. So basubiye inyuma basanga afite ibimenyetso bya systemic lupus erythematosus. So now that was the cause. So the patient was treated kugeza ubwo yanavuye kuri za dialysis aba umuntu umeze neza nk'ubusanzwe. So he was lucky because as you saw, people having this focal segmental glomerulonephritis usually they progress to chronic renal failure. So question so far. Okay, so we can have a break. Maybe 15 minutes break, and then we'll proceed afterwards. So welcome again to the presentation. Hope you can see the screen and hear me. So we have done with nephrotic syndrome. Now we are going to start the nephritic syndrome. As I said, the nephrotic syndrome, as we saw, it is about the loss of proteins through urine associated with edema, and then increased lipids in the blood. And you have seen different diseases, each of which can be the cause of nephrotic syndrome. So nephritic syndrome, so this is a glomerular disorders characterized by glomerular inflammation and bleeding. As I said, there is inflammation and there is hematuria. So it can be associated with proteinuria, but it will be less than 3.5 grams per day. The threshold we saw for nephrotic syndrome. It can be associated with oliguria and azotemia, salt retention with periorbital edema and hypertension. So periorbital edema, and we saw for nephrotic syndrome that also these patients, they have edema, but it starts, of course, on the face. So red blood cells cast and dysmorphic red blood cells in the urine. These are features associated with nephritic syndrome. So biopsy will reveal hypercellular inflamed glomeruli. So in mesangium, you see that this glomerulus is very busy having many cells. Normally, you could see very few cells if you compare with the diagram we saw with photomicrograph we saw when we started the previous section. Usually, this is also associated with immune complex deposition, which activates the complement system, and the complement 5A attracts neutrophils, which will damage the kidney or the glomeruli. So in this nephritic syndrome, we have different diseases, and among them we have this. First one. So this is a nephritic syndrome that arises after group A beta hemolytic streptococcal infection of the skin, such as in impetigo or the pharynx. So nk'uko twabibonye bitera ibibazo ku mutima, endocarditis and so on. Also it affects the kidneys. So it occurs with nephrogenic strains, meaning that the strains of streptococci which can cause nephritic syndrome or nephritis. It may occur after infection with non-streptococcal organisms as well. So, but the most common being the the group A beta hemolytic streptococcal infection. So these changes within the kidney, they appear 2 to 3 weeks after the initiation of the infection, and they present as hematuria with Coca-Cola colored urine, so brownish, red brownish, oliguria, hypertension, and then there is the periorbital edema. So here we have four signs. While in nephrotic syndrome, we saw 3 cardinal signs. Ahangaha kandi urine ntabwo ziba zitwara kubera ko this is not fresh blood, kuko hemorrhage takes place at the level of the glomerular, aho twabonye bagira gross hemorrhage niba abandi bafite necrosis around the papilla of the kidney. So on histology, we'll have inflamed hypercellular glomeruli on hematoxylin stain and mediated by immune complex deposition. That's why immunofluorescence will be positive with some granules. So there's a granules, each granule refers to a deposit. Also, there will be subepithelial humps on electron microscopy. And the treatment is supportive, meaning that you must treat symptomatically until you get rid of the cause, or probably this patient will need a replacement of the kidney. So children rarely progress to renal failure, while 25% of the adults will progress to rapidly progressive glomerulonephritis. So you see that the children, they can survive because few of them will progress to renal failure. Otherwise, in the adults, most of them, they progress to the worst condition. So rapidly progressive glomerulonephritis, it is shown here. So this is the glomerulus. It is sclerotic in most of its parts, and here you have increased the number of cells. And even around in the interstitium, we can see some inflammatory cells. These are lymphocytes. So let's change the. So we have lymphocytes here. So nephritic syndrome in this condition will progress to renal failure in weeks or months. It is characterized by crescent in Bowman capsule of glomeruli. As I said, crescent, it means a section of the glomerulus here. This part is sclerotic. So it is a segmental glomerulitis, we can say so. So crescents are comprised with fibrin and macrophages. So this is low power. So fibrin you can see, but macrophages you can notice this is low power. Clinical picture, or meaning you must compare the clinical picture and immunofluorescence in order to know what was the cause. So meaning you combine the clinical information or findings with the immunofluorescence findings in order to have the final etiology, the final diagnosis, and the diagnosis are listed on this table. And here it is, this figure is showing just a deposit anti-basement membrane antibody. So they used it and then it became positive, meaning that this person was having deposits around the glomerular basement membrane. So according to the type, to the pattern of immunofluorescence and the other findings, then you can have the final disease, Goodpasture syndrome, this diffuse proliferative glomerulonephritis, and so on, Weigener granulomatosis, and so on. So these are the possible causes, depending on what you have seen on histology and on the immunofluorescence and the clinical signs and the symptoms. Other diseases in nephritic syndrome. Sorry, there is stopping me to. Okay, so here we go. So IgA nephropathy. So here we have a problem of deposit of immunoglobulin A, immune complex in mesangium of glomeruli. Ngira ngo ubushize nigeze mbivuga uko izi complex zibaho, ni ukuvuga umubiri ufite an agent, and a certain agent which came somewhere as an antigen, then umubiri ukoherezayo antibody such as IgA, yagerayo aho kugira ngo wenda ineutralize ya antigen, ahubwo ikiyunga nacyo kigahinduka immune complex. Umubiri wakongera ukohereza indi antibody nayo yagenda ikiyunga na bya bindi gutyo. So nuko bigenda bikura binini until they cannot be lost within the urine during the glomerular filtration. Ahubwo kiba ari kinini kinyura muri pores, ahubwo kikaba deposited, then causing more problems. So that's how IgA immune complex will deposit in mesangium. So this is the most common nephropathy worldwide. It presents during childhood as episodic growth or microscopic hematuria with red blood cell casts tuza ari utubumbe twa red blood cells muri urine, usually following mucosal infections. So ugasanga ni umwana wari umaze igihe afite gastroenteritis cyangwa afite za angina and so on. So IgA production is increased during infection. That is the meaning. So IgA immunocomplex deposited in mesangium is seen on this. So it means they have used things which could detect or attach or react with IgA. Then they stent the kidney with that. There's a special stains, fluorescent stain, and become positive because they found IgA there. This may slowly progress to renal failure. So another condition seen associated with nephritic syndrome is the Alport syndrome. So this is the inherited defect in a type 4 collagen. Most commonly, it is in X-linked. So nimusoma cyane chapter yerekeranye na healing and repair muzasanga ari indwara nyinshi zirenga 17 zikomoka kuri collagen, and this is because we have many types of collagen. So nubwo tubona collagen fibers, they are of many types. I think more than 20 types. So each type of collagen, when it has a deficiency or deficit, then it can cause a disease. So Alport syndrome, this one is caused by now that the problem in type 4 collagen. So there will be thinning and splitting of the glomerular basement membrane. So basement membrane will not be fitted to do its function. And the patients will present with hematuria, sensory hearing loss, and ocular disturbances. So then on kidney. But this is a syndrome, of course, Alport syndrome. Ngira ngo muri zimwe twabonye malformation in the morning, this Alport syndrome should be there. So that's all for nephritic syndrome. Any questions so far before we go to the urinary tract infection?
Sorry, Rector.
Yes.
For the Alport syndrome, is Alport the disease? Because you told that syndromes are like signs of the disease. Can you consider Alport as disease, or it is like a linked signs that you can use to diagnose the nephritic syndrome?
This is not just one disease. It is a set of signs and symptoms in which you can have different diseases. So, for example, some who have Alport syndrome, they can develop the nephritic syndrome. Others, they don't. They can develop just hearing problems or eyes, vision problems. So in genetics, you know that not everybody who has a inherited mutation develop the disease. So there are some who don't develop. There are some who develop it very early, or they develop some of the aspects of that disease, but they don't develop others. So someone can have an Alport syndrome, but not develop any disease. Or one can develop, let's say, nephritic syndrome when he's a child, another one when he's more advanced in age. Undi akagira ibibazo bya vision and so on. So Alport syndrome is not a diagnosis. It is not a disease entity. It is just a set of manifestations which can refer to different diseases. Other questions? Okay, so we proceed with infections. So here we have infection of urethra, bladder, kidney, ureter, and so on. most common causes arise from ascending infection nyamukuru nayo ascending no iva hasi izamuka ishobora kuva muri urethra cyangwa ikava muri sexually transmitted diseases you don't know cyane cyane ku badamu because the organs are close to each other so ikazamuka ku bagabo birumvikana urethra ihuriweho na urinary system and the male genital system. So na infection yaho ishobora kuzamuka either ikagana muri za prostate which will be in the male genital system or ikagana muri kidneys urinary system. So the bacteria there they ascend. It is common. Ikindi uko ishobora kuzamuka ari iatrogenic ni ukuvuga bitewe n'uburyo umuntu yavuwe wenda umusizemo sonde cyangwa catheter ikazamukana na infection yari iri aho ngaho kuri external genitals and so on. So most commonly arises due to ascending infection, increased incidence in females. So this is a sin. So akenshi bivuga ko ikibazo ari abadamu ari abagabo bashobora kugira sexually transmitted disease and so on, ariko abagabo kubera ko bafite urethra ndende bacteria kugira ngo zizazamuke zitera ibibazo biragoranye kurusha abadamu bafite urethra ngufi. So the risk factors include sexual intercourse, urinary stasis, and the catheters, so as I was mentioning. So we can see the first one is cystitis. This is the infection of the urinary bladder. Present as a dysuria, difficulty in urination, urinary frequency, urgency, and the suprapubic pain. So I think these signs you saw them in the module. Signs and symptoms. So urinary frequency ajyayo kenshi, urgency aba yumva yakubwe kandi yanagira agasanga na ni dukeya, and the urinary suprapubic pain because it is where the urinary bladder is located. And the systemic signs are fever, but this is usually absent. So ubundi bivugwa ko umuntu agira umuriro iyo afite urinary infection, agira umuriro yo infection yarenze urinary bladder yazamutse hejuru. Ni ukuvuga yageze muri ureter and kidney nibwo ashobora kugira umuriro. This is in general. So nubona umuntu afite urinary tract infection akagira umuriro, usually the infection will have reached area above the urinary bladder. So the laboratory findings, urinalysis, the urine would be clouded with more than 10 white blood cells per high power field. So arana amaserire menshi white blood cells. So kuvuga ko ari cloud ni ukuvuga ko ibishaka kujyana kuba pass. So deep stick, that's a procedure they do in lab. There will be positive leukocyte esterase. So kwa harimo leukocyte or white blood cells, there will be esterase. So esterases are very positive, and also the nitrates will be there because the bacteria, when there are bacteria within the urine, they convert nitrates to nitrates. So actually your reaction chimique ntabwo ushobora kuba waratari bacteria nicyo bisobanura. So once they see that nitrates instead of nitrates, it means there are bacteria which have transformed nitrates to nitrates. They confirm there are bacteria. So uko muzabona mu akenshi bigenda ntabwo muri urine iyo bazipimye bahita babona bacteria, ahubwo ziba ari nkeya ku buryo kuzibona bisaba culture. So kugira ngo bakore culture nabwo rero ntabwo bakora culture ya urine yose, nuko babonye harimo leukocytes nyinshi cyangwa a deep stick yabaye positive. So yabaye positive baba bati harimo bacteria, but now the next is to know which bacteria, and you understand the reason is that they must identify which bacteria and do a sensitivity test to know which drugs will kill that bacteria. So niyo mpamvu yo white blood cells babonye nta zirimo hatarimo nitrates. So deep stick ari negative ntabwo birirwa bakora culture kuko bivuga ko nta bacteria, so no need to do culture. So culture, so it is the golden standard test here. ko niza izemeza burundu ko harimo bacteria iniye cyangwa se fungus, then and they will do a sensitivity test to know which drug will work on that microbial agent. So the causes of cystitis, the most common is the Escherichia coli. Others are Staphylococcus saprophyticus, in which the incidence increases in young people, who especially sexually active women. But Escherichia coli. Other agents are Klebsiella pneumoniae and the Proteus mirabilis zikunda kugira resistance kuri antibiotics cyane, so they are not easy to treat this one. Another one is the Enterococcus fecalis. So kirango ushaka kubona koko ifite ihuriye na feces, so probably it is coming from the rectum and then ikaza no muri urinary system. So sterile pyuria is the presence of pyuria. Pyuria, it means a lot of white blood cells and leukocyte esterase, but with a negative urine culture. So it means babonye za globule rouge blanc nyinshi, white blood cells nyinshi, then baba bati hari bacteria, bakora culture bakayibura. So bijya bibaho. So this suggests urethritis due to chlamydia trachomatis. Kako parasite ntabwo bazikorera culture, so culture ikorerwa fungi and bacteria usually. So icyo gero zira white blood cells zaba zirimo na esterase irimo, leukocyte esterase irimo kubera ko haje white blood cells which were there but fighting against a parasite, or this bacteria Neisseria gonorrhoeae, which is not captured muri media zisanzwe. So they have their own capture media. So pyelonephritis, this is inflammation of the pelvis of the kidney and also the nephrons, of course. Infection of the kidney, usually due to ascending infection, increase the risk with vesico-ureteral reflex. So when urine comes from the urinary bladder and it goes upward to the ureters, usually this patient they have a risk to develop pyelonephritis. Patients would have a fever because this is above the urinary bladder, flank pain, and white blood cell casts, and leukocytosis, meaning that white blood cells are increased within the blood stream. So, in addition to the symptoms of cystitis, so the most common pathogens are still Escherichia coli, Enterococcus fecalis, and Klebsiella species, Klebsiella mirabilis, and so on. So murabona ko ahantu henshi Escherichia coli nikunze kuba yiganjemo. So meaning that ushobora kuba uri kuvurira ahantu utazi neza uko byagenda kandi ugomba kwtelefona udashobora gupima ngo bamenye bacteria biteye aho. If it is justified by your protocols, then you can give a drug, you know, it will work on Escherichia coli, though you have not isolated it because of the facilities you have there. So chronic pyelonephritis, this is associated with fibrosis and the atrophy of the tubules due to multiple bouts of acute pyelonephritis. So nukuvuga umuntu ahora agira recurrent acute pyelonephritis, ageraho akagera rero ikahindukamo chronic pyelonephritis. So in children, this is due to the reflux from the urinary bladder to the ureters, or obstruction in the people who are in the adults. So like BPH, this is benign prostatic hyperplasia in men, and cervical carcinoma ni nabyo bikunda kwica abantu. So umuntu ufite benign prostatic hyperplasia, which is not cancer, barapfa cyane bishwe nuko habaye obstruction, urine igasubira hejuru, so there is the reflux then damaging the kidney, and until they have a renal failure and so on. The same for cervical cancer, abarwayi bayo benshi nicyo kibica ni renal failure kubera obstruction. Because the cervical cancer usually invades the urinary bladder and obstructs it. So they have a cortical scarring with varices, scarring of the upper and the lower pores, characteristic of vesico-ureteral reflex. So ikindi nuko tubules zihinduka, they become atrophied in their epithelium, ahubwo zikaba cystically dilated, as you see here. Umenyereye histology of the thyroid wagira ngo ni thyroid, because thyroid no kuba imeze filled with colloid, but this is not. So niyo mpamvu bavuze thyroidization of the kidney, ni ukubera kidney kuri histology hano gusa na thyroid gland. So another condition after these infections, so of course, ntabwo twagiye muri sexually transmitted diseases, which are many, chlamydia, the syphilis, and toxi. So there are many parasites. So we go to nephrolithiasis. Nta kindi bivuga nuko afite gallstone, not gallstone, afite stone muri urinary bladder, ariko ushobora no kuba ahandi ho hose, ushobora kuba muri kidney, ushobora kuba, as you see in these pictures, they are in the pelvis of the kidney. You can see the stones here, and it can be, well, I want to give muri urinary bladder. I remember when I was, I think I had finished the second year medical school in Butare, nagiye ku bitaro hafi y'aho iwacu, hanyuma kwimenyereza stage y'ubushake kanga nimenyereza ibyo kwa muganga amenye ko bigenda. So nibuka haje umuntu, umudamu wari ufite fistule, vesico vaginal fistula, yatewe yari afite ibuye muri urinary bladder, nibuka ko yari santimetero enye muri diameter, so it was large. So mu kwexamina kuko babonaga harimo ikintu kuri x-ray, boherejemo sonde kafete ariko ifite akabuto k'icyuma, hanyuma yakuraho kumva birajegera koko baremeza bati ni rero bagomba kuribaga. So nukuvuga kubera yabanye na infection igihe kinini, agira deposit this lithiasis kiba kinini kugeza ubwo habaye necrosis of the wall of the bladder, then with fistulization to the vagina. So urine we zamanukaga muri vagina. So baramubaze bagikuramo, but as you know, to repair fistula is very difficult. It takes a lot of time. It is not a thing you can do in one surgical operation. You do many surgical operations to repair it. So they are common, especially abantu bakunda kugira cystitis, chronic cystitis, akunda kuba deposit of calcium, hakongeraho izindi zimanuka muri urine until it becomes a very large stone. So risk factors include high concentration of solute urinary filtrates and low urine volume. So birumvikana mu kubirwanya, icyambere ni ukunywa amazi yahagije buri munsi, bituma hatabaho urine concentrate cyane, kuko ibyo bigira risk. Presents as colic pain with hematuria and unilateral flank tenderness. Iki ariko ni ikiri muri kidney. So nephrolithiasis, here it refers to the stones within the kidney. Mu gihe yamanutse hasi ntabwo bayita nephrolithiasis. So azaba aribwa hejuru muri flank kubera ko kidney ariho ziri. So rimwe na rimwe gashaka kumanuka kagera muri ureter kagafatirwamo, cyane cyane aho kagenda kwinjira muri urinary bladder. So hakaba obstruction, umuntu aba aribwa cyane. So that's why they say colic pain. Colic ni uburibwe bukomeye cyane, bimeze nko gupfanyuma. So the stone is usually passed within hours. If not, surgical intervention may be required. So there are here the composition of each diseases, the frequency, the causes, and the treatment. So some are caused by calcium oxalate, others ammonium, magnesium, others uric acid, others cysteine, and so on. And you see the causes. Some they are just caused by infections, others by other problems. So now coming back to renal failure, but now the chronic one, nibwira ko byinshi nabivuze ko cyane cyane mvuga ku buryo bwo kuzitura buhari, ko nta kindi kiba gishoboka uretse gusimbuza impyiko icyo cyakoraga, gishobora gusimburwa na dialysis cyangwa se umuntu agahabwa another kidney. So chronic renal failure is sometimes called also end stage kidney disease failure. So ngira ngo muzamubona abarwayi cyane cyane muri unite z'ibitaro, teaching hospitals, ari byo bifite dialysis centers, ari CHUB, CHUK, King Faisal, Kanombe. I think there's a 4 which have na Gisenyi ifite nayo nephrology service bashobora gukora dialysis now bafite facilities. So otherwise, in other district hospitals, when you have such cases, you must refer them as emergency to these hospitals for them to do dialysis. So this is the end stage kidney failure. It results from glomerular, tubular, inflammatory, and vascular insults. Nyangu byinshi twayibonye ari nephrotic syndrome, bya bindi bigize ari nephritic syndrome. Yes, twabonye ko bishobora kuganisha hariya kuri renal failure. So, but the most common causes are diabetes, mellitus, hypertension, and glomerular diseases. So they present with uremia and why of the uric acid nyinshi mu maraso kubera ko glomerular filtration yakwikura mu maraso ntabwo ikuba ko bikwiriye. Salt and water retention with resultant hypertension. So salt and water will be retained because filtration doesn't take place, of course. Salt will not go, and when salt doesn't go, water also will not go. Hyperkalemia with metabolic acidosis. There will be anemia due to decreased erythropoietin production by renal, peritubular, interstitial cells. Murabizi ko ari kidney ikora erythropoietin. So niba amaseri yakoraga erythropoietin yarabaye damage, therefore ntabwo izakorwa, kandi iyi hormone nizatuma habaho gukora izindi red blood cells within the bone marrow. So the treatment will be dialysis and renal transplant. So this is what I had explained, and we have seen also that usually these patients who undergo dialysis, they have a risk of developing cysts. So and also there is increased risk for renal cell carcinoma. This is a cancer arising from the tubules of the kidney. So that is in general what we can say about the chronic renal failure. So it is an end stage kidney failure or end stage kidney disease. So igira amazina menshi, igira no hari za research ziri gukorwa CH ikaba nyirango zombi banditsemo end stage kidney disease. So it means the same. So kuba umuntu afite kidney failure rero ntibivuga ko that is a disease per se. You must know the cause of that. Okay, so going to tumors now, we start with the benign one, angiomyolipoma. So you can see angio means vessel, myo muscle, and lipo, this is lipids or adipocytic tissue. So it is a tumor combining three types of cells or lesions. So there is an overgrowth from the vessels, blood vessels, from muscles, and from adipose tissue. So because of that, it is not a true tumor, we call it is a hematoma. I think last time I explained the hematoma. So where we have a succession of different types of tissue which come back in a disordered way. So you find the muscle where it should not be. So there is a location of abnormal location of a normal tissue, that is hematoma. So it is there is a high frequency of angiomyolipoma in people who have tuberous sclerosis, these are syndromes. So it is a syndrome, this one. So you can see a tumor here, which is just is closer to the kidney. Akenshi ifatira muri iriya fat ikikije kidney. Aha ngaho yagiye muri kidney mbere ntabwo iri inyuma, so it is below the capsule of the kidney, inside. So this is histology. Ahari clear cyane, these are lipocytes. So otherwise we will have a smooth muscle there and some vessels inside. So this is a CT scan. It is showing this is a kidney, another kidney have the liver. So in these kidneys, you can see area which is black. So it means it is less solid than other parts of the kidney. And here we have another one. So they are shown by the arrows. So otherwise it is just benign. It will be removed surgically. So renal cell carcinoma, this is a cancer. Ni cancer ifata abakuru, ifata abana turayibona nyuma. So iriho cyane iyi renal cell carcinoma. Ntabwo ari nyinshi cyane ariko zirahari. Ngira ngo last time nari ndi kuvuga umurwayi dufite SH wari ufite bayivuwe mu myaka 5 ishize surgery, and then akaba yaraje afite metastasis around the liver, in the liver and around it. So it arises from kidney tubules, presents with classic triad. So triad ni ibintu bitatu ugomba kubona, hari hematuria, flank pain and palpable mass. So kiba ari kinini nubwo kidney ubundi nta wiparuka ngo yumve, ariko iyo harimo imaso urataruka icyuma. Hari igihe ukibona gusa umurenge ari hari bitanakoze. So these are 3 signs which show that a person may be having renal cell carcinoma: hematuria, palpable mass, and flank pain. Otherwise, twabibonye kare, unufite nephritic syndrome azashobora kugira flank pain and hematuria, but there will be no palpable mass. Umuntu ashobora kugira palpable mass akagira na flank pain, n'urujya afite angiomyolipoma ariko ntabwo azagira hematuria. So ibi bintu bitatu bihuye ku muntu mukuru, so be very cautious about it. But they say that they rarely occur together. Sometimes you find 2, not or 3. But hematuria is almost always present. Other signs are fever, weight loss, so cancer, and paraneoplastic syndrome. Byabiri bavuze ko umuntu agira ibimenyetso by'uburwayi bwa organe adafitiye ikibazo, ahubwo kubera ko kanseri iri gukora hormone zikorwa n'indi organ idafite buriye n'ufite ikibazo. So ahangaha niho uzasanga umuntu afite hormone nka ACTH nyinshi. This is parathyroid hormone, actually releasing protein. I don't remember this protein. So releasing protein and so on. Murumva ko izi hormone zose ntabwo zikorwa na kidney ariko azazigira. So erythropoietin yashaka kuyigira, byo birumvikana ko this kidney is where the erythropoietin is made, and the renin also it is synthesized within the kidney. So kugira increased renin na erythropoietin byo byakumvikana, but there's 2 others is not. So rarely it may present with left-sided varicocele. Involvement of the left renal vein by carcinoma blocks the drainage of the left spermatic vein, leading to varicocele. So ntabwo ngo varicocele ni reka tuwe pari nka so stagnation of blood and so on the scrotum. So the right spermatic vein drains directly into the inferior vena cava. Hence, the right-sided varicocele is not seen. So that explains why when it is the left kidney which is affected, then these people they can have left-sided varicose. So on a gross examination, so here you can see the picture of this is a true picture of kidney. It was dissected. You see that there is a solid tumor above. Hasi igice cyo hasi mu ku kidney ubundi bisa cortex ahagana kuri calyces haba hari whitish. So iki gice byo hasi niko kidney bisa ubundi. So hejuru ahangaha it doesn't look like the normal kidney. It has another architecture. The pathogenesis involves the loss of von Hinder and what Lippers gene, which is on chromosome 3, the short arm, and this is a tumor suppressor gene. It's the P53. And also because this gene, because of this loss of VHOL gene, there is increased IGF-1 and increased HIF, this hypoxia-induced factor, transcription factor, and therefore there will be increased vascular and endothelial growth factor and platelet-derived growth factor. Ibi byose bishobora gutuma gusobanura impamvu abantu bafite renal cell carcinoma ibiva cyane. Aha nibyo bitera hematuria, ariko umurwayi navugaga nabonye mu byumweru bike bishize. So when I aspirated to deliver, so there was too much bleeding. So ku buryo I was skeptical nari ndi kwanga nta maserire nashoboye gufata kubera too much bleeding. But when I stayed there were a lot of cells. So they bleed very easily. So kwa kwari kuva nasabye radiologist narebe niba iri vascularize aho no kuri ecography ugasanga there are very few vessels, but it was bleeding a lot, so it was somehow confusing. So this is the nature of renal cell carcinoma. So the staging will be based on TNM, as you know, T for the primary tumor, N for metastasis on lymph nodes, and then M metastasis to the distant organs. So on histology ugira ngo ni fat cells, aya ni amaserire ya renal cell carcinoma, ariko urabona ni ibintu by'umweru gusa bivuga ko it has nothing within the cytoplasm. So niyo mpamvu akenshi muzasanga tuyiripote nka clear cell carcinoma, because we don't see anything in the cytoplasm, we call them clear cells. So iyi ndwara iyo ibonetse kare abantu babakira. Maybe I told you that. So one of my professors in residency, Professor Bet, aho nige yari yaragize renal cell carcinoma. So ariko kubera ko yari ahantu hari advanced babibonye hakiri kare baramuvura, ari muri retirement, ariko he has nothing, no problem. He has no problem because bayimuvuye hakiri kare nta kibazo yigeze agira. So ikibazo gihari nuko kenshi abarwayi baza baratinze yarageze kure ku buryo kumuvura agakira burundu bitoroshye. So these tumors may be hereditary or sporadic. So this is about the causes. So is it inherited, especially the mutation in von Hippel-Lindau disease because of having inactivation of this gene. Indi mpamvu cyane cyane izwi ni ukunywa itabi, cigarette smoking. It can be passive or active. Utarinywa ahubwo uhorana n'abantu barinywa cyangwa uba ahantu barinywa. So all this may expose someone to have it. So this diagram is showing how to stage it. So here you see that it is in one pore and it is less than 7 centimeters diameter. Here it is more than 7 centimeters in one pore, so stage 2. Stage 3, you see that it comes to the renal pelvis hilum, and it comes even to the renal vein until to the vena cava. And here it has gone far from the vena cava in stage 4. It went even to the regional lymph nodes, so stage 4. So you see that maybe if you diagnose it at the early stage, stage 1 or 2, it will be more prone to be cured. But stage 3 and 4, especially 4, the cure is almost impossible. So the tumors in children is Williams tumor. This is an eponym. It was described for the first time by someone called Williams. So otherwise, the histogenic name is nephroblastoma. So it's an embryonic tumor showing features of the embryonic kidney. So it is a malignant tumor. It has 3 components. Blastema. So this is the immature kidney parenchyma and the primitive glomeruli and the tubules. These are, we call them epithelial cells, and then or abortive epithelial cells and stromal cells. So ni indwara iba mu bana kugera ku myaka 3 mbo hari n'abagera ku 10 hano. And I remember just a few years ago, there was a case reported at the King Faisal Hospital, so it was really exceptional. Ubundi ni indwara itapfa kugaragara mu bantu barengeje imyaka 10. So it is usually a large tumor, unilateral flank mass. Nubwo hari abagira bilateral tumors. Bilateral tumors, you see them. Papa nibuka pari hariho arutwaye memo baramubaga idini imwe yari yarafashwe yose bayikuramo indi bakuraho igice cyari cyarafashwe basigamo agace gato kugira ngo kabe kamufasha uwo mwana muri glomerular filtration. They have a unilateral flank mass with hematuria and hypertension. So birumvikana ko hari ibyo ahuriyeho na renal cell carcinoma, harimo flank mass and hematuria. So they will have hypertension because they secrete too much renin. Remember the physiology, renin, angiotensin, and aldosterone, these things, how they play a role in the blood pressure. So most cases are sporadic. Syndromic tumors also exist. Maybe 10% of these tumors are syndromic, meaning that arise from syndromes inherited from parents. Hari ita WAGR syndrome, so abbreviation for Williams aniridia problems with iris. So genital anomalies, abnormalities, and mental retardation. So this is seen when a patient is having a deletion of the gene WT1. So W2 ivuga Williams tumor n'ubundi bayise gutya ko bazi ko ufite ikibazo agira Williams tumor, but after time it was seen that this mutation can be seen in other cancers. So I remember in the sequencing we have done on the genomes of patients affected by acute myeloid leukemia. During my PhD training, there are some patients who had a mutation in this WT1 gene. Bafite leukemia, but bafite Williams tumor. Another syndrome is Dennis-Drush syndrome. They present with Williams tumor, progressive renal glomerular disease, and male pseudohermaphroditism. And this is associated with mutations in WT1, not deletion. So Beckwith-Wiedemann syndrome, ngira ngo karevuzo kare abo bagira na n'ibindi bibazo birimo rhabdomyosarcoma tukanabibonye muri other issues on malformations on the face, head, and neck, including tongue, they have a glossoptosis and so on. So for them, they have mutations in the cluster of WT2, not WT1, gene cluster. Is it WT1 iba kuri chromosome ya 11, WT2 iba kuri chromosome nayo 11, short arm region 15, mugire ayo iri kuri region 13, so ntawe ziri ahantu. So this is a diagram to show how Williams tumor is. So there is no big difference. Uyibonye kuri bayibaze na renal cell carcinoma. Itandukanye nuko nephroblastoma ikunda kugiramo necrosis, ikagiramo zones. You can see that they are like cyst. yereke cyst. So hari n'igihe bagira ngo ni polycystic kidney disease kandi ari nephroblastoma kubera agizemo uducyste twinshi. So the components are saying blastema, you see these are the differentiated cells, tubules, you can have some glands, and then the mesenchyme here. So mu buryo bwo kwivura nephroblastoma ni ukubabaga n'imiti, chemotherapy, maybe radiation. Ikibazo ku isi harimo uburyo bubiri igihugu cyose gihitamo ubwo gikoresha. So hari ibihugu bihitamo kubanza kubaha imiti bakababaga nyuma. Abandi bakavuga no ntabwo twamuha imiti tutazi neza ko ari nephroblastoma, reka tujye tubanza tumubage tubanze pathology yemeze ko ari nephroblastoma tubone kumuha imiti. So there are two classes or schools on this. So u Rwanda rwo protocole bahisemo hano nuko nabo babanza kumuha imiti bakamubaga nyuma. So kumuha imiti bakamubaga nyuma avantage ni ibyo bita down staging, igihe cyari kinini cyane kiragabanuka kikaba gito ku buryo kukivanamo cyose bikunda. Niyo protocole ikoresha babanza bakamuha imiti, ariko n'ibintu biba biri ku mibare neza bibaze ku buryo bati twebwe tumuha cycles z'imiti wenda 5 cyangwa 6 wenda bizamara ibyumweru 3 cyangwa 4 gutyo. Itariki iyi ni turatangira imiti, itariki ni byanze kuza kugomba gukorerwa surgery. So protocol ya mu Rwanda nuko imiti itangirwa Butaro, surgery igakorerwa CHUK, hanyuma pathology CHUK igasubiza ifite iminsi ntarengwa yo gusubiza kuvuga icyo twabonyemo, hanyuma umurwayi akongera agasubizwa nawe ku miti nanone. So niyo protocol. Ikibazo kizamo iyo habaye nka stock out of reagents cyangwa se stock out ya consumables bakoresha muri surgery, icyo gihe hakabamo gukererwa. It compromises the management of such cases. Otherwise niko protocol imeze. So imwe muri imbogamizi duhura na muri pathology nuko hari changes ziba muri nephroblastoma zisa nanone na changes zitewe n'imiti umurwayi yamuha. So hari izo tubonamo ugasanga hano hajemo bone tissue cyangwa cartilage. So icyo gihe ntidushobora kumenya ngo iyi cartilage yajemo mbere muri tumor cyangwa se yatewe n'imiti. That we can't. But otherwise these are minor things, nta kibazo. Icyo tugendera cyane kurera ni ukugira ngo ese imiti bamuhaye yakoze umurimo niba warakoze neza, dusanga almost all the tumor is necrotic. Imiti yarabyishe byose, amaserafi yose yarapfuye. Ariko ari research yakozwe n'umwe mu bari abanyeshuri bacu mu postgraduate barangije umwaka washize, byagaragaye ko rates yabo imiti ikuraho tumor ikayimaraho burundu cyangwa ku buryo buhagije ni ntabwo ari nini ugereranyije n'ibihugu byateye imbere, nubwo imiti dukoresha ari imwe ugereranyije n'ibindi bihugu. So we ask ourselves the reasons. So we want to investigate if there are molecular aspects which differences between our population and the other population, explaining why our population doesn't respond well to the drugs while in other areas they respond. So, but that will be explored in further researches. So otherwise, these are frequent tumors. As I said, for retinoblastoma, these are more frequent in the western part of Rwanda, and the reasons we don't know yet. So the lower urinary tract carcinoma, as I said, there are many types of tumors in the urinary system, but the most common one is carcinoma. So it can be urothelial carcinoma because you know from the ureter up to the urethra we have a urinary, the lining epithelium is urothelium. Ntabwo ari squamous cell epithelium, nta nubwo ari a glandular epithelium. So ibyo bituma n'ubundi kurusa zigera kuri 90% za carcinoma ziboneka ahangaha hose ari urothelial carcinoma. So squamous cell carcinoma ni nkeya ndetse na adenocarcinoma. So it can be seen again here, urothelial carcinoma 90%, squamous 5%, and around less than 5 is the adenocarcinoma and then small cell carcinoma and so on. So the urothelial or transitional cell carcinoma, it arises from urothelium lining the renal pelvis, ureter, bladder, and urethra. So the major risk factors are cigarette smoking. Ibindi ni abakora ngira ngo muri neoplasia twarabibonye, abakora mu nganda zikora niftaramine, azodize cyangwa abazinywa long term cyclophosphamide or phenacetin use. Iyi ni imiti n'undi kare kwa muganga. So generally these cancers are seen in older adults, classically present with painless hematuria. After hematuria but without pain. Babonye ko afite hematuria na pain akenshi ni renal cell carcinoma cyangwa se infection, nephritis, but ahangaha ntabwo baribwa. So when you see that, be very careful. So niyo mpamvu screening ishobora gukorwa iyo afite kanseri amaseri yaramanuka muri urine. So gufata urine gusa bakazipima muri cytology, muri pathology barazibona ko harimo abnormal cells. So it arises from two different pathways. So the first one ari nabyo bigaragara ngaha bibanza ari flat. As you saw in this histology, it has a smooth surface, ariko nyuma hazamo papillary component, utuntu tumeze nka cauliflower souffle tuza nyuma. Not ntabwo tuza nyuma, ni uburyo bubiri, bamwe batangira ari flat abandi bagatangira ari papillary. So the papillary pattern is not associated with P53 mutation, while the flat ones are associated with P53 mutations. So the tumors are often multifocal and recurrent. So that is a problem. Ushobora kusanga kimwe muri urinary bladder, ibindi muri urethra and so on. So squamous cell carcinoma nubwo bimeze gutyo, nubwo tuvuga ko nyinshi ari urothelial carcinoma, iziri mu bihugu byacu East Africa, personal uko nabibonye ni squamous cell carcinoma niyo nyinshi. Ibi bisobanurwa nuko abenshi babiterwa na infections. So iyo umuntu agize infection muri urinary bladder ikamara igihe, the urothelium will be metaplastic, so it will transform itself into squamous cell epithelium. Ibyo bibaho cyane cyane kuri abantu bagira chronic cystitis, abagira infection by schistosoma hematobium, kari ifata urinary system bakunze kubigira. So ahantu baturi ibiyaga cyangwa ibishanga bakora mu bishanga bakunze kugira ibibazo squamous metaplasia, so leading to squamous cell carcinoma. So schistosoma hematobium, especially abantu bo muri Egypt bakunze kugira iki kibazo ku buryo bukomeye. So and of course those having lithiasis, long-standing lithiasis. So adenocarcinoma yo iza buri gihe iturutse kuri urachal remnants. So the dome of the bladder, ngira ngo murabizi sac vitelline sac yindi muri itunga kana kakiri gato mu nda, ahantu ibiri iyo placenta ije sac vitelline itakaje agaciro, ariko hari abagira remnants yazo. Izo remnants rero iyo zitavuyeho burundu zishobora kwinduramo adenocarcinoma. So it is a granular one. So I personally saw one case of adenocarcinoma of the urinary bladder. So that is in general the cancers which can affect this area. So in our context, the most common I can say it is squamous cell carcinoma because of infections which are long-standing, not treated, and also those working with bakora mu bishanga, mushrooms and so on, kubera schistosoma hematobium. So ikindi tugomba kwitonda, and you will know nidusubiza muri pathology twavuga ngo umuntu twasanze afite carcinoma ariko afite na schistosoma. So you must know how to deal with these patients, kuko ntabwo tugiye wemerewe kumuvura cancer utaramuvura schistosoma. So they always start with the schistosoma itself, then bakabona kumuvura cancer. So schistosoma nta nubwo ifata gusa, murabizi hari izifata muri digestive system, especially hematobium, schistosoma mansona, while the hematobium usually affects the urinary system. So I remember, so we had the case, hari umuntu wari ufite paralysis, babona afite mass muri spinal cord. Then when it took biopsy, we found it was just a schistosoma infection. So bamuha imiti and then atangira kuimprovinga. So we published that case because it was interesting. So it can affect any organ. So we are done. So if you have a question, you can ask them. Otherwise, we will end by here. Any question? Okay, so it seems there is no question. Then we'll end here, and I will send also this presentation because I haven't yet sent it. So also I would ask, when do you want, because there was a request to do as much continuous assessments as possible. So when do you think we will do your first continuous assessment test?
Please, how will it be prepared?
Sorry?
How will it be prepared?
You are not prepared. So when will you be prepared?
Next Monday.
Next Monday? Okay, you will let me know. So we will have the next lectures on a Friday. So on Monday you can have your continuous assessment test. Maybe for the chapters covered until today.
May you give us only about two?
Sorry?
Two of the chapters you've discussed.
Only two?
Yes, it could be better.
Why? When will other
So
chapters?
we are because it is continuous. Maybe we can continue doing even the assignments for the other chapters.
No, two chapters will be very little.
It could be better for us even.
Correction, you can try it in January.
January. Okay, ni
Yes.
mwebwe mwavuze ko ngo muba mukeneye exams nyinshi. None January is the end of the lectures. Kandi mwe mwavuze ngo mushaka ibizami byinshi. None January it will be the end of the lectures. So how will you do many exams in 1 month?
Sorry.
Lecture.
Okay, so
icyo numva cyaba cyiza. Hello lecturer.
Yes.
Narimo ndavuga ngo icyaba cyiza ni uko twakora nyine assessment kuri two chapters, noneho izindi zisigaye tugakoraho assignment.
Assignment ese yashoboka kuri izo chapters zose?
Yes.
Sorry. On 28th, we have another cut. That's why we propose on January, like on the first date of January, because this December on 28th, we have the cut of microbiology. That's why we are supposing to have it in January. If possible, we may propose
Okay.
the date. January.
Okay, so you will let me know. You will let me know.
Yes.
So see you on Friday.
Thank you.